Hi, my name is Eric Vanderlip. I'm an assistant professor at the University of Oklahoma School of Community Medicine. I'm in the departments of medical informatics and psychiatry, and I'm a board-certified family physician and psychiatrist. This is the first of a series of webinars on integrated care, specifically the blending of behavioral health services and primary care services. We'll be talking about a number of topics during these seminars, and I'm really excited to start it out with one of my favorites, this notion of integrated care. That's who I am, and that's what we'll be talking about today. I don't have any disclosures. I don't make much money other than what I make through the University of Oklahoma. I want to start us off with a case. The first case is Doc Brown. Some of you might be familiar with his character. He is a 46-year-old white male with chronic schizophrenia. He's been on long-acting injectable haloperidol for around 10 years and relatively stable with just 1 or 2 hospitalizations with intensive case management, thanks to your services at your community mental health center. 18 months ago, after Doc's last hospitalization, he was switched from olanzapine. He was switched to olanzapine in addition to his long-acting IM haloperidol decanoate. Olanzapine is also known as Zyprexa. It's an antipsychotic medication to help manage psychosis. As you imagine, Doc might be a typical community mental health client. He spends extra money on canned foods, energy drinks, marijuana when available, and rolls his own cigarettes. He weighs 287 pounds, and his BMI is almost 38. Looking back in 2011, which is the last time your community mental health center has records on Doc, his BMI was 27, almost 28 at that time. So quite an increase in his BMI over the last few years. Additional chart review of his recent labs reveals a hemoglobin A1C of 6.1%, a total cholesterol of 260 milligrams per deciliter, an HDL of 33 milligrams per deciliter, and a blood pressure of 156/95. You are a new-aged community mental health provider, and you think this might be alarming. I might be a little bit worried about Doc, because now you know, and you've been through these webinars, and you know that Doc's main cause of mortality is cardiovascular disease, heart attacks and strokes. You are enterprising, and so you go online, and you enter these key numbers into your spreadsheet, your online database. This clinical risk calculator, which if you follow the link on the app or on the slides from the previous page you can get to, highlights the modifiable cardiovascular risk factors for Doc. The reason I'm bringing this all up is because these are the things we can change, and these are the things we must change, and this is what's driving integrated care. The modifiable cardiovascular risk factors for Doc include diabetes, his cholesterol values, whether or not he's on treatment for hypertension, his actual systolic blood pressure or the top number of his blood pressure, and then whether or not he's a smoker. We can't modify things like his age, his gender, or his race, though they're still risk factors that we need to consider. When you plug this in and hit enter in your online calculator, you arrive at this, that Doc, over the next 10 years, has a 19% chance of a heart attack or stroke. That's large. If I've already had a heart attack or a stroke, my average risk over the next 10 years of having another one is 19%, or 1 in 5. Doc is virtually on the same level of risk as somebody who's already had a heart attack or stroke. Here's the other fascinating thing about this. If we control Doc's modifiable risk factors, we can bring that risk down to 1.3%. Doc is an example of our populations that we're trying to care for in community behavioral health. And this is what the promise of integrated care brings to us. If we can control these major risk factors, we can shorten significant mortality gaps for the persons we're trying to care for. I want to transition, though, because integrated care isn't just about the docs of the world and bringing primary care services to behavioral health settings. It's also about the other end of the spectrum. It's bringing behavioral health services to primary care settings. We'll be talking about both of these in this introductory webinar. So you can imagine Eeyore. Eeyore is a client of your primary care clinic or your federally qualified health center. Eeyore is a 36-year-old male donkey who is seeking treatment for dysthymia and depression. He's always down. It could be worse, maybe never get better, I don't know. He's always morose. Eeyore, because of that, is at risk for a number of things. We'll talk about those. But he presents in primary care. And if we rely on the typical primary care services and infrastructure to deliver behavioral health services, getting Eeyore to behavioral health care feels like a brick wall. It's nearly impossible sometimes, in part because our funding mechanisms are different, the geographic provision of care is different, but then also because Eeyore may not want to go to a different place to get his mental health care. And maybe on top of all that, Eeyore may not want to get mental health care, and then even further, there may not be available behavioral health providers to see Eeyore in those community mental health places or those specialty behavioral health settings. We know this from pretty good epidemiologic evidence. Eeyore is a drain on everyone and everything. He's also more expensive to take care of. He has poorer outcomes, is in the hospital more. He's more likely to die from a heart attack or suffer from a stroke by virtue of his major depressive disorder. He's less likely to be employed or worse, show up underemployed or be present but not fully attentive to his work duties. He doesn't show up for appointments. He doesn't show up for referrals. He's stuck. You're all stuck like molasses. You don't know what to do. He doesn't know what to do. He's an anchor on his tail. You just want him off to someone else. Why the heck doesn't he take his meds? This is like what a primary care physician or provider is thinking when he's thinking of Eeyore. They're frustrated and they're stuck. And we've got to be able to deliver evidence-based behavioral health services in those primary care settings. That's another part of integrated care. So one of the main points of this introductory lecture is to introduce you to the notion that integrated care is a two-way street. But basically, we're talking about bringing behavioral health services to primary care settings, and then vice versa, bringing primary care services to behavioral health settings. That's what this slide depicts. The field of normal integration, or bringing behavioral health services to primary care integration, is much more advanced and much more developed. We know a lot more about that than we do about the opposite, bringing primary care services to behavioral health settings. But nevertheless, we're trying both. And both of them fall under this category of integrated care. The other thing that I want to point out to you today is that integrated care is a continuum. It's not just yes or no. It's a whole spectrum of ways that we can work together, from kind of loosely integrated, partly integrated, to super highly advanced integrated care programs. And I want you to be able to appreciate that spectrum after the webinar this morning, or today. So less, more. On the less side of things, I have what we call basically parallel play. Traditional medicine, traditional healthcare services, where somebody is seen in primary care and needs referral to behavioral health and doesn't get there, or gets there, but the two never actually intersect, never communicate together. And the opposite, the most, is something I would call uniplay, where one individual person is simultaneously integrating thoughts and perspectives from the behavioral health world and thoughts and perspectives from the medical world. That person could be a combined trained person like myself with family medicine and psychiatry credentials, or just shy of that, an integrated team that meets consistently, regularly to collaborate and work together to formulate treatment plans for people. That's all this in between. We're going to briefly review some of the reasons and rationale behind this impetus towards behavioral health integration in terms of bringing behavioral health services to primary care populations. And so I want to talk to you briefly about the prevalence of behavioral health in primary care populations and settings. I want to talk to you briefly about the toll, including the high burden and high cost of behavioral health disorders. And then we're not really going to get into the advantage of these models. We'll talk some about that in later lectures. Behavioral health is highly prevalent in primary care. 80% of the time, 84% of the time, the top 14 unknown conditions, or top 14 conditions presenting to primary care, have no organic etiology, meaning there must be some emotional or behavioral component to them. These are things like nausea, dizziness, chronic pain. They're highly common in primary care, and there's a huge behavioral health and emotional overlap to these disorders and their presentation in primary care. 80% of people with behavioral health disorders will visit a primary care physician or clinic at some point in a calendar year. And probably the biggest other thing here is that 50% of all behavioral health disorders are treated in primary care. From this slide, you could tell as we accumulate physical disorders like obesity, diabetes, asthma, the odds of us also having a behavioral health disorder like a substance use problem or a formal mental illness also increase. So for somebody who has, say, 3 chronic physical conditions like obesity, asthma, and diabetes, their odds of having a behavioral health condition like a mental illness, something like depression, are almost 4 times those without as many chronic conditions. This is also showing you the pie graph of how we distribute behavioral health treatment in the United States. The vast majority of people actually get no treatment for behavioral health services, those who may need it, and we know that from large epidemiologic surveys. Of those who do receive care, the 40% who do, just over half, about 6 out of 10 of them, will receive care in primary care settings. And the other 4 out of 10 of them may receive care in specialty behavioral health settings. So you can see that we've got a major problem with delivering behavioral health services to all those who need it in the United States. This slide gives us more of the data behind that. You can see 2/3 of those with a behavioral health disorder, like I've already mentioned, just don't get treatment by certain studies. We also know that 30 to 50% of those referrals from primary care to behavioral health settings never make their first appointment. And if you also combine that with the fact that at 6 months of follow-up, only roughly half to 40% of those who were initially seen for behavioral health or behavioral health treatment in a specialty medical setting, or a specialty mental health setting or a primary care setting are still engaged in care, at 6 months after initial diagnosis and referral, only 18% of those who were initially referred are still in treatment. That's abysmal. And the last I checked, depression and most of our behavioral health disorders were things that need to be managed over time, meaning we've got to figure out ways to engage populations and enroll them and keep them coming into care so that we can follow up and make sure they're managing it well. If we look at all of that pie of who needs a behavioral health assessment, and we assume that they need to see a psychiatrist, for instance, in urban places, that psychiatrist would need to see a new patient every 6 minutes, in order to meet the demand for psychiatric services out there. That's never going to happen. And there's never going to be enough psychiatrists, psychologists, or behavioral health specialists necessarily to get us all out there to address all of the behavioral health conditions in the world. We've got to rethink our approaches. This is primary care behavioral health integration. This is bringing mental health services to primary care settings. We also know that if you're not treating behavioral health conditions, there's a huge cost and a huge burden associated with that. This is a study looking at the top 10 costliest conditions for employers in terms of dollars per 1,000 full-time employee equivalents. And you could see depression is responsible for nearly $350,000 per 1,000 employees of expenses and time lost. The vast bulk of that is from this green stuff called presenteeism, which is a fascinating concept. Presenteeism is this thing that's under the surface of the water. It's when you show up to work, but you're not fully plugged in or engaged in your work. You're distracted. You're not paying attention. And it's lost productivity because of things like depression. That actually accounts for a huge economic burden on our society. And something that we've never been great about measuring until more recently. We also know that if you add depression to any of these chronic medical conditions like blood pressure, asthma, diabetes, or coronary artery disease, it greatly increases the cost of managing just those conditions. It's much more difficult to get on top of diabetes or blood pressure if you're also depressed. It's much more costly. And so we've got to be able to somehow recognize these behavioral health disorders in primary care. That's part of integrated care. So If we flip it on its end and think about the need for doc, like we were talking about, to get better primary care services in behavioral health settings, then we have to examine the epidemiology around that epidemic. There are thousands of docs out there with serious mental illness, and this slide reviews some of the basic epidemiologic facts around this population. We know that persons with serious mental illness in the United States will die, on average, persons with any mental illness, between 10 and 25 years earlier than age-matched counterparts who have no mental health conditions in the general population. For all adults with any mental illness, it's around 8 years. The even scarier part of this is that this mortality gap, this gap in how long people with serious mental illness will live compared to the rest of us in society, appears to be widening over time. Over the last 2 decades, we're not shrinking it, it's getting further. Part of that is because you and I, who lack serious mental illnesses perhaps, have access and more routinely get access to evidence-based treatments, preventive care. We can go in and advocate for ourselves better in the hospital and get access to heart catheterizations, for instance. That's on the next slide. So it turns out that those with serious mental illness primarily die from heart disease and stroke. This has been shown over and over again for the last 10 years, and it's only becoming more prevalent. Although persons with serious mental illness are also at risk for dying from a number of other conditions. So virtually everything is worse when you have serious mental illness. Your dental problems are worse, your skin problems are worse, everything is worse. But if we take a hard-nosed look at the absolute risk of death and what's the single cause or major conditions contributing to this early mortality, it's cardiovascular disease by far and away. Part of that is that when you show up to a hospital, and this was shown in 2001, with something like schizophrenia and ST segment changes on your EKG, which is a sign of a heart attack, we know that you're 40% as likely as somebody else without schizophrenia to go for a heart catheterization. We've known that since 2001. That's where this mortality gap starts to come into effect. This is a study from one of those Danish countries where they have really good databases to track and see what's causing mortality amongst their different populations. And this is a study looking at specifically women with schizophrenia with a diagnosis of coronary artery disease versus those without a diagnosis of coronary artery disease. And this graph is showing their standardized mortality ratio. I'm not a big numbers guy, but the thing I want to point to here is that in this Danish country where they were able to have universal health care coverage, the women who were between the ages of 35 and 85 who had somehow been involved with the healthcare system and gotten access to care had an average ratio or mortality from cardiovascular disease that was almost on par with the general population. Those who hadn't been enrolled in care, those who didn't have a prior or existing diagnosis of coronary artery disease, had an elevated mortality. I think in part because they didn't get access to preventive health care. And that gap, it's due to recognition of these conditions. So this aspect of involving people in their care, getting them evidence-based treatments to lower those modifiable risk factors is where we're seeing, I think, where we see a large part of this mortality gap playing out for the docs of the world. So if we put it all together and we have a ruler, if we assume the average life expectancy in the United States is 78 years, and those in the US with any mental illness is around 70 years, minus 8 years, those with SMI have an average life expectancy of 70 or 55 years. SMI is serious mental illness, severe mental illness. This is the mortality gap, this red splotch, 20 years. And I estimate about 60% of that or so is due to provision of evidence-based primary care and preventive care, controlling those modifiable risk factors. And what we've got to do is be able to fix that access to care problem through better integrated care services. That's why we're talking about integrated care today. So there's two forms of integrated care, and it's also a continuum. So there's the form that is for the docs of the world, that is reverse integrated care on the bottom. Then there's the form for the Eeyores of the world who want their behavioral health care in primary care settings. You also need to know this other thing. This is the point of this introductory lecture, that integrated care is this spectrum between parallel play, kind of the idealized version of what we have today, where they get a referral and then they get managed over time in behavioral health and the two never talk. And then uniplay, which is somebody, like I was mentioning earlier, who's all infused and combined and has all this stuff and is able to synthesize a treatment plan simultaneously in their head with the person sitting across from them. All the in-between can be conceptualized as this. From a less integrated model, like a parallel play model, you get co-located care, which is one approach to bringing behavioral health services, for instance, to primary care. That model basically just puts a behavioralist or a behavioral health specialist in a primary care setting. There's no systematic integration. There's no protected time for the two of them to meet. They may not even share the same electronic medical record. But yet, this can provide convenience for the Eeyores of the world so that they can get behavioral health care services in their primary care clinic. It may help overcome some of the stigma around behavioral health treatments. But co-located models haven't been robustly shown to produce significant outcomes and cost reductions in care. That's just the fact of the world. I've worked in a number of co-located models, and it's very challenging to find the time to meet and synthesize treatment plans. It just doesn't happen regularly. After a consultative model and you co-located model, it's a little more integrated. Consultative model is even less integrated than a co-located model I was just describing. You get a collaborative model. And collaborative care is something we'll be talking about in the next couple of webinars. But collaborative care is something that's evolved out of the science of chronic care management. SAMHSA, the Substance Abuse and Mental Health Services Administration, has put down around 6 different levels of integrated care. And you can look at this at their integrated care website, which is the Center for Integrated Health Solutions. If you just Google SAMHSA and Center for Integrated Health Solutions, you'll come around a bunch of resources and you'll find this listing of the spectrum of integrated care. I throw this up there just because it's out there. I don't think of this a lot in my clinical practice. I think about, in our systems design, I think about basic constructs of collaborative care, and I'm trying to work towards that. We'll talk about those in a minute. But I want you to be aware of these resources and that there's this spectrum. As I was mentioning before, there are some distinct advantages to a co-located model of behavioral health and primary care services being integrated. And in these models, I'm mainly talking about primary care integration, bringing behavioral health services to primary care. The bulk of what we've been trying to do in terms of bringing primary care services to behavioral health settings have been mainly primary care or co-located models without a lot of true blending, despite what people may say. There's advantages to co-located models. They're easy to implement. They kind of fit squarely into our current notions of healthcare and how we deliver healthcare. They don't necessarily challenge providers to work outside the box or think about how they can communicate with others. In fact, we can get by pretty easily in a co-located model, just working shoulder to shoulder without talking much. The challenges are that in a co-located model, if I operate as a same old psychiatrist, my caseload pretty quickly fills up. And all of a sudden, I don't have any more appointments available, and I can't see any more new patients. Because I don't have quite the capacity to leverage myself across a population. I'm still seeing people one-on-one. And that's difficult because, as you know, there's never going to be enough psychiatrists. We've got to figure out a way to break that up a little bit. That being said, the collaborative care model or the collaborative behavioral health model for co-location and bringing behavioral health services to primary care is also challenging. It's harder to implement. It costs more money, or it has different payment structures that don't really fit nicely into our current healthcare system. And so we are lagging in implementation of collaborative care for a number of reasons. When we're thinking forward to these things, part of the next step in the next webinar will be reviewing some of the history of collaborative care, namely how it evolved out of this thing, which is called the chronic care model. So our next webinar is going to be a review of this, the chronic care model. as an example of how we can use that to better guide our integrated care services. So today, we've been talking a lot about integrated care already. Integrated Care 101, this has been an introduction. You need to know that integrated care is the blending of behavioral health and primary care services. It's a two-way street, that we take behavioral health services to primary care and primary care services to behavioral health. And the reason we do this is because there's people in both settings that need better access to both of these service lines. The question before us is, how do we best integrate these? That's what we'll be talking about in the next couple of webinars. I have some idea that it has to do with teams. Thanks.